So, our next session is entitled When Common Symptoms Aren't Common, Cancers Hidden Behind Digestive Complaints, and this session is sponsored by Merck. Joining us is Dr. Jessica Briscoe from Morehouse School of Medicine. Her work zeroes in on colorectal cancer disparities and how nutrition, weight, and systemic inequities show up in digestive health. Also, in guiding the discussion is Dr. Patricia Sanseer-Hager, Chief Operations Officer at Black Health Matters, where she turns big health equity goals into real community level impact. Ladies and gentlemen, please welcome Dr. Bristow and Dr. Sanseer-Hager.
Good afternoon, everybody, again. And thank you so much for that wonderful introduction. I have the pleasure of being here with Dr. Briscoe, who's a gastroenterologist.
Good afternoon.
She just told me only 1% Black females are gastroenterologists. Give her a round of applause, please. That's unbelievable. Yeah. So when common symptoms aren't common, cancers hidden behind digestive complaints, we're going to talk about that and have a discussion. Just to frame it up, Dr. Briscoe, when patients come to you and everyday complaints like heartburn, bloating, maybe changes in bowel habits, this might have been going on for a long time. What are the risks of not being able to figure out whether or not it's something significant or something just, it's a normal digestive issue?
Yes, I love this question. What I always say to patients is it's not your job to decide if something is more serious or not. It's your job to tell me as the provider what your body is telling you. And I will help you to differentiate and go through and decide if it's something that we need to monitor or something that needs more evaluation. Digestive complaints, of course, are very, very, very common, but they can also mask more serious underlying conditions, most seriously cancers. And so always bring any of these complaints up to a provider to make sure that you are not missing anything.
So that's great. It's, don't wait. Ask your doctor the questions if you have any concerns, anything, right? Because you don't know. Can you break down for us those symptoms? We hear acid reflux, we hear GERD. I remember when my daughter had acid reflux and took her to ENT, and I was like, what is that? I didn't know it happened to someone so young. And we hear these symptoms, constipation, but what are the ones that are characteristic with signs of maybe cancer?
So I wouldn't say that it's necessarily a specific symptom, right? All of those digestive complaints are common. Probably everybody in this room has experienced one, if not all of those. What I tell patients to think about is things that are lasting for a long time, not getting better, things that are worsening or becoming more intense, or things that are associated with what we call alarm signs. So lowering of your blood counts, anemia, unintentional weight loss, vomiting, difficulty swallowing, blood in your stool. None of those things are normal. There can be benign causes, but none of those things are normal and should be evaluated.
And what would be like a major red flag is like, but if there are any things that are like absolutely, you better go to the doctor?
Yep, any of those things that I just mentioned. So blood, anemia, unintentional weight loss, vomiting, difficulty swallowing, and then also any individual who has a family history of GI cancers. Do not wait. Bring this information to your provider because one, that could change your screening interval and may even prompt other evaluations and specialty evaluations that you are unaware of.
So self-medicating, there's a lot off the shelf. How many people have Tums at home, right? Antacids, right? Tea, my family was Haitian, so we have a lot of tea, a lot of soup. How do you measure whether or not over-the-counter medications are the route to go versus you really need to do something more?
Yeah, and what I would say is, again, digestive complaints are common. I mean, literally yesterday, I was walking through a grocery aisle of all the digestive things that you can buy today. And I do that every so often because you as patients come to me and say, well, I got this thing and I got this thing. And the first thing I'll ask is, bring it up so I can look at the ingredients, because that's another thing you have to be careful of. Sometimes these additive ingredients can cause other digestive complaints. So I'm that type of doctor. But what I would say is that because they're so common, it is okay to, get something over the counter to treat your constipation or to treat your GERD. What you need to pay attention to is, hey, I've been trying these things and it's not getting better. And don't wait 6 months, after a month or so, you really should bring it up to your provider. And I would say if you have any of the other associated alarm signs that I talked about, don't wait till your next appointment. You call and make, an appointment and say like, hey, this is my concern.
So let's talk specifically about esophageal cancer. Let's start with that. And there's screening for it as well. What are you recommending that we should be looking out for in terms of symptoms that are related to esophageal cancer?
Yeah. So in the United States, there is no guideline screening program for esophageal cancer specifically because of the low incidence rates. However, individuals who have had acid reflux, even if it's been controlled for over 5 years, and multiple of these following risk factors, so obesity, age greater than 50, smoking history, family history of esophageal cancer, should be evaluated by a gastroenterologist. And what we would be looking for, we would think about scheduling you for an upper endoscopy. So that's a procedure that I do where we use a camera and look inside your esophagus, your stomach, and the first part of your small bowel. And what we're screening for is actually a pre-malignant lesion called Barrett's esophagus. Has anybody ever heard of Barrett's esophagus? So Barrett's esophagus is where the lower lining of your esophagus actually changes related to repeated exposure to acid. Acid's supposed to stay in the stomach, but when it's allowed to keep coming up to the esophagus, it causes damage. And Barrett's esophagus is a precursor to esophageal cancer. So we can actually intervene on Barrett's esophagus and treat that, and we monitor that and surveil it because of that risk.
And how are we doing as a community? I was reading recently about the incidence rates, which are lower, as you said, for Black and brown people, but the mortality rate is much higher. How are we doing?
Yeah, and in general, the incidence is lower. However, when esophageal cancer is found especially in African Americans, it's typically found at a later stage and literally due to delayed diagnosis, right? So that's when we think about these things, which brings me to my original point. Anytime you're experiencing a digestive complaint that is repeated and ongoing, always bring it up to a provider. And if you feel like you're not being heard, you ask for that specialist referral. Say, you know what, I want to see a gastroenterologist. Like, who do you recommend, or can I get a referral?
All right, let's move to colorectal cancer. Colorectal cancer is one of the most preventable cancers, thank goodness. What are the current screening recommendations, and why is starting early so important to get that screening done?
I will stand up on my soapbox for this. I wore my blue for colorectal cancer screening month next month in March. Colorectal cancer is the 4th most common cancer in the United States and the 2nd deadliest cancer in the United States. 2nd deadliest cancer in the United States. And it is completely and 100% preventable and preventable, so preventing it from happening, and also curable if found at an early stage. What's recommended is for average risk individuals, so folks who don't have a family history of colorectal cancer, no alarm signs like I mentioned previously. Screening should start at age 45. Everybody say 45. That is a change, and there are still some providers who are recommending age 50. That's incorrect. Age 45, it's what's recommended by all our societies, and that decrease in age is actually, we're noticing an increase in incidence of colorectal cancer in younger individuals, and we don't know why. So that's one thing, and there's disparities in colorectal cancer. African Americans also have delayed diagnosis, often found at later stages, which are less treatable.
I've seen those Cologuard commercials, and during the Super Bowl, there was another commercial that was interesting. What are those different screening options? Can you share a little bit more about that?
What's great is that we have multiple options for screening today. And what I say is the best screening test is the one that you're actually going to get done. Because again, delayed diagnosis, delayed evaluation is what harms us. So there's two buckets. One is the two-step tests and one is a one-step test. So the two-step tests are our stool-based colorectal cancer screening tests, like the Cologuard, like the FIT test. Basically, it's not glamorous, but it will save your life, is you get a kit and you take a small sample of your stool and it's looking for microscopic blood and abnormal DNA in the stool. Take the sample at home, no prep, no nothing, in the privacy of your own bathroom, put it back in the kit that it was given to you in, and you mail it back to the lab. And a result will come positive or negative. Positive doesn't always mean cancer. Actually, it's like for Cologuard, maybe 2 to 4% of the positives are cancer, and for FIT tests, maybe 3 to 8% of those are positives. But positive could also mean you have a precancerous lesion that needs to be removed by a gastroenterologist like me. And then there are a subset of those that are false positives. So what positive means is that you will need a colonoscopy for definitive diagnosis on why that is positive, because that's the only way we can tell. And then the one-step screening test would be going straight to the colonoscopy. So the colonoscopy is a test that I do. It's a procedure. You have to prep for the procedure, which is probably the most challenging part because you have to drink.
All that liquid.
Okay. Yes, the prep. The prep is, the most difficult part. I tell patients it's a salty fluid. There's lots of different preps, but unfortunately, sadly, insurances don't cover all the different and new preps that we have. We at Morehouse are doing a study, so we're getting some smaller volume preps for our patients for free. So that's an amazing thing that we're doing. But in general, the prep is the most important part because it cleans out all the stool in the colon. And if it's not clean, we can't see very well. And you would have to repeat it if I can't give you a good exam, because I can't say that I didn't miss something. Because we can miss something even in a clean colon. But a colonoscopy is diagnostic and therapeutic. So that means I can 100% rule out colon cancer, but I can also find lesions that are called polyps that are precancerous, and I can remove them during that test so they have no chance of ever becoming cancer. And this test, if it's completely normal and you're an average risk individual, you can get up to 10 years before you need another one. The FIT test and the Cologuard FIT test you have to keep doing yearly, and the Cologuard you have to do every 3 years. So again, whatever screening test you're going to complete, just get it done. And for those individuals who have a family history or any alarm symptoms, you need a colonoscopy. Stool-based testing, even if it's offered to you by a provider, is not appropriate.
And is it uncomfortable? I know when I had it done, I waited till I was 40. I won't say how old I am now. That'll be the next prize, if you can guess. But it wasn't that bad because I was put out, right? And then I did the prep and I got up and, I didn't go to work the next day. I took a day off just so the anesthesia could wear off, and I was okay. And I think I took a pill or something that they gave me to prep with, which was great. Is that the general experience for most people?
Yes, like I said, the toughest part literally is the prep. You are going to be asleep for the exam. Oftentimes when we're rolling patients into recovery, they're like, "Did you start the test yet?" I'm like, "It's done."
So it's easy, go get it done. At what age did she say? 45, 45, exactly. Let's talk about diet and lifestyle factors. We often, as humans, edge towards what we can control, right? If we can make a soup, like I said, or make a tea, exercise, there's a lot of gut health diets out there. What would you recommend that people should be thinking about from a lifestyle factor standpoint?
Yeah, these questions are very common, and it makes sense, right? Because the digestive tract, this is your organ that absorbs your nutrients. It is literally where the food goes into, so it's going to be affected by your diet 100%. I think what is challenging is in, today's world of like social media and influencers is people always tell you that this thing is the thing and you have to do this thing. And I think that it's just not generalizable to every patient. Everybody's gut and gut microbiome is exposed to all different things, which changes it. And it changes over time and it changes as we get older. So there are a few things that I mention to patients consistently that may affect you. So one is something called FODMAPs. Has anybody ever heard of that? FODMAPs? So FODMAPs are just different types of carbohydrates that actually ferment in the gut. They can be found in dairy is a common one. They can be found in fruits and juices and things like that, something called fructose, which is like a simple sugar. These types of carbohydrates can ferment in your gut and cause a lot of GI symptoms. Now, everybody who's exposed to them doesn't necessarily have those symptoms, but these are things that I start to tell patients. I categorize them and I say, think about these things and see if there's anything in your diet that you're consistently consuming and maybe try cutting that out to see if it makes a difference. One thing that I will tell you is that high fructose corn syrup is in a lot of things in America. Your salad dressings that we think are healthy, lots of sauces, all those things, it's like an additive, a filler, but that fructose portion of it can actually cause a lot of symptoms in your GI tract. So those are some of the recommendations that I start to talk about with patients. And then other things that I think about are things that increase or decrease your cancer risk. So red meat and processed meat. There is a strong correlation in individuals who consistently consume red or processed meat. It increases your risk of colorectal cancer. And then alternatively, fiber. If there's one thing that people leave my office talking about is fiber. Fiber is that girl. Like fiber is the thing to do. It improves your gut health. It improves your bowel movements. It decreases your cardiovascular risk. It decreases your colorectal cancer risk. And often in the American diet, we don't get enough fiber. We need at least 20 to 30 grams per day. And so I often recommend plant-based fiber supplements.
If you had to visualize like 20 grams a day, what is that? Like a nice plate of salad with broccoli and
it's
what's
not
on
actually,
it?
when you look at like salads and things like that and like your sides, those maybe are like 10 grams, 15 grams. So you'd have to eat it multiple times throughout the day, which is why I tell people you probably need to just start a supplement. So however that looks for you, if that's taking some psyllium, as an additive or doing something in like a shake, those are things that I consistently recommend.
Awesome. So before we wrap up and talk about patient empowerment and self-advocacy, I want to turn to the audience to see if there are any questions for Dr. Briscoe about your gut health, about colorectal cancer, esophageal cancer. Any questions? Right over here. We'll bring a mic to you.
Someone over here? Question? Anybody? Oh, right there.
Can diverticulitis revert to colon cancer?
So thank you for that question. Well, the question was, can diverticulitis revert to colon cancer? So
That's what you were gonna ask.
diverticulosis is where the wall around the colon weakens, the muscle wall weakens, and you develop a pocket, a little outpouching. It's called a diverticula. Some people can live and die with that and never even know that they have it. Some patients bleed from them, and some patients get infections from them called diverticulitis. What we tell patients and what is evidence-based is that if you have an episode of diverticulitis and have not had a high-quality colonoscopy within a year of that event, you should, at least 6 to 8 weeks after that event, have a colonoscopy to make sure that there was no underlying lesion or mass or cancer that could have precipitated that diverticulitis.
Any other questions?
Yeah.
What would you attribute to the increase of the colorectal cancer? Is it diets or air or whatever that's tripping? Because it seems like there's such an increase, or is it because we're becoming more knowledgeable about it and we hear more?
Yeah, I think that there are a lot of definite environmental factors in general, like the American diet, like we said, ultra processed foods also increase the risk, and some of those things. Um, I think overall, the increase in younger individuals, we really don't know why that is happening. And there are researchers all around the country who are actively trying to understand that. And so, really, that's why the messaging, even more so about screening and paying attention to your body and paying attention to symptoms. Things like even rectal bleeding. Has anybody ever had a doctor tell you, like, oh, that's probably hemorrhoids? Even if it is probably hemorrhoids, rectal bleeding is never normal and deserves an evaluation, because I can tell you, sitting here today, I've diagnosed several patients who were told that they have hemorrhoids and they actually have rectal cancer. And this is not to scare you or frighten you, but what it means is, like, don't ignore symptoms. Symptoms can have a benign cause for sure, 100%, but we always need to make sure that there is nothing else underlying that. And especially in folks who are at screening age or above screening age, those symptoms should be taken even more seriously.
You said the earliest age to have the colonoscopy is 45?
45.
What is what is the latest, like the oldest, like 80s, 90s?
Oh,
No, seriously, because my
Yeah.
mom, she
Yeah.
had to have one. They gave her one. She passed away at 89 and she had hers in 80s and she was clean. I had one like a couple months ago and I had polyps. So what is the oldest age?
This is a great question.
And she did great. I was so proud of her.
Awesome. So the recommended screening age is 45 to 75. Between ages 75 and 85, we say it's a discussion between you and your doctor for shared decision making. So why do we say that, right? Because if you get a colonoscopy at 75 or even age 85 and you get a 10-year interval, will we still be screening you at 95? Do you know what I mean? And so your risk of developing a cancer at that point becomes much lower, and the risk versus the benefit of the procedure doesn't balance out, if that makes sense.
We do have time for a few more questions. I see a couple of hands up, one here, and then there's a hand up in the back, Deidre, as well.
Thank you for this. This is excellent. I had a hemorrhoid. I did it 40A exam, and one of your colleagues removed it, thankfully. I'm asking the question of what is the guideline for my children, because I had a adenomatous polyp. What would be the guideline? I know 45 is, but there has to be a rule for that. Can you share that?
Great question. Yes. So when staying on top of it, you got your colonoscopy and a polyp was removed. The things that you need to know is twofold. One, make sure you get a copy of your procedure report, so that way you can know what was found. And two, make sure you get a copy of your pathology report. So when we take out polyps, we don't always know what type of polyp it is. There are polyps that are specifically precancerous, and there are others that are totally benign and could never turn into cancer. So if you have a precancerous polyp, what are the factors that determine your next colonoscopy? It depends on how many you have and the size. So those are important. For your family members, what matters is your age and the size. So 1 centimeter doesn't sound large to you all, but that is a polyp that's larger than 1 centimeter is considered a higher risk polyp. So if you have a higher risk polyp, your children or your siblings, if they're younger than you, should start their screening actually 10 years earlier than the age that you had that higher risk polyp. So if I come at 45 and I have a 1.5 centimeter polyp, my kids need to start their screening at age 35.
In light of the age being 45, where you're recommending for people to start getting colonoscopies, because of the increased incidence of younger people being diagnosed with colon cancer, should that age be reduced now? Are they considering that?
The short answer is we don't have an answer for that at this time. As research continues to evolve, they're going to monitor the situation. Right now, what is evidence and guideline recommended is 45. Why that's important for patients is because that's when it's going to be covered by insurance. Now, remember, screening is different than symptoms. If you have symptoms that deserve an evaluation, that's different. That's not the screening pathway. So you still present, and if a colonoscopy is indicated to evaluate your symptoms, then that will be done.
Okay, we have a question from our virtual audience. Is there a higher risk of esophageal cancer with a silent reflux diagnosis?
Reflux in general can increase your risk for developing changes related to reflux. And so, you know, it would be important for this individual to continue monitoring with like a gastroenterologist and follow their symptoms. So if it's silent, that's challenging because there aren't any symptoms. So there is testing that we can do to see if there is continued acid reflux. Like we can measure acid, and gastroenterologists do these type of procedures. And then with your provider, develop a plan for monitoring and treatment.
Is it a good idea to take dairy out?
I'm sorry?
Can you repeat
Is
that,
it a
please?
good idea to take dairy out of your diet? Like,
Take dairy out of your diet. Is it a good idea to take dairy out of your diet?
Again, I'm of the camp that there's no absolutes. There are great things about dairy, like yogurts, Greek yogurts. Those have a lot of our like probiotics and good bacteria for your gut. I think again, you have to monitor how these things affect you and how you feel after them. The enzyme in your gut that actually helps you digest dairy, lactose. Most of us, if not all of us, will become lactose intolerant at some point in our life. And so the lactose load in different dairy foods differs. So that's why you may see a difference like, oh, I'm fine with yogurt, but if I try to have a cup of milk, I have diarrhea. So again, paying attention to your body, doing things in moderation, and having fiber.
Right. In moderation, in moderation. Do we have time?
One last question.
All right, last question.
Yes, I wanted to ask you, do you have a suggestion? Like when I eat yams, beans, or anything like that, I always get heartburn. Gravies, all of that. And I'm just wondering why I get it every time I eat it.
So there's no easy answer for that because this isn't an office visit right now. But what I can tell you is that most likely it has to do with what either is in the sauce and gravy, because all these things can affect that relaxation of the bottom of your esophagus and allow acid to come up. The fat content matters, the acidity matters, and all those things. So it's important to touch base with your provider. If you're having consistent symptoms of acid reflux, that deserves to be treated. And again, like we mentioned today, if you're having persistent reflux over a long period of time, you should be evaluated by a gastroenterologist.
Thank you all for your questions. So a couple of call to actions around patient empowerment and self-advocacy. Dr. Briscoe, how should people be prepared when they go to the doctor if they're experiencing these symptoms, especially if they're persistent? What are your top 3 recommendations on what they should come prepared to talk about?
What I would say first is understand the provider that you're seeing. Are you seeing a primary care doctor or are you seeing a specialist? If you are seeing your primary care doctor, when you come, they have a set agenda based on your age of things that they need to cover. And so you also need to come with your agenda. If there is something that has been happening to you that you are concerned about, bring that up in the visit early. Say, hey, this thing is happening to me and here are my symptoms. And at that point, you can work together to develop a plan, whether that means a specialist consultation or other testing. So that's one thing. 2, if you do end up going to a specialist, you are going for that one thing that they sent you for, okay? So if you come to a specialist and you tell them all the other things, your message will get lost. So make sure you understand who you're seeing and what you're seeing them for, to make sure you can tell them clearly what your body is telling you, so that they have all the information to help make decisions and tests beyond what is going on there.
So 45.
Yes, 45.
Younger, if you have a polyp sized, as you said.
If you have family history of colorectal cancer or polyps, then your screening interval is shorter, and you may need to start sooner depending on when they were diagnosed. Average risk individuals start at age 45, can do any of the tests that were previously mentioned. And if you have symptoms, do not wait, do not wait, do not wait. Come present your symptoms. You may need an evaluation.
And bring your agenda.
And bring your
And
agenda.
bring your agenda. Thank you so much, Dr. Briscoe. This was so informative. Excellent. And I believe she has one slide that she wanted to show about free screening opportunities for colorectal
Yes.
cancer at Morehouse.
So we're going to have a lot of information online, instructional videos, statistics, things that you can do. And we're also going to have a colorectal cancer awareness day at Grady where you can do free screenings, where you'll be able to interact with gastroenterologists and other providers like myself. So if you have family members that it's been challenging to get them in, we're hopefully going to have a big colon that you can walk through and we can do some education. So we're going to have a lot of programming. So there's the information there. And yeah, thank you so much.
Thank you, Dr. Briscoe. Thank you, everybody, for your participation.